Yes, guys. So now we are now arriving at some chat, some questions, some answers from the speakers. They have spoke fantastic. Thank you very much for timely presentation, which gives us time for some interaction. As I noticed from all the four presentations, you are using some app and some medical devices, either for collecting data or some vitals or something like that, right? So all four of you using some medical device, if I say so. My question to you, how you ensure that your medical device which you're using is working correctly? It means, in other sense, how do you validate these medical devices, whether it is like Avisha is using blood test analyzer for some blood test, someone is using ECG, somebody is collecting something, you mentioning ICUs, and stethoscope in DISCUSION, Hasayam, and all many other things. So how you make sure your devices are working fine? Anyone can pick and then you go on.
My
Yes.
answer is easy, so I'll just try. So we work in the ICU primarily and in high acuity settings. We are not hardware manufacturers, so we rely on existing hardware standards and just ensure that these devices comply with whatever the current existing industry standards are, whether it's FDA or CE, doesn't matter. And typically we would go with brand names that are already established in the market with their own standards that are already in the industry. So we're not reinventing anything there.
Fantastic. Thank you, Dilip. Yes, Saji?
Yeah, and especially I'm dealing with these patients who are asked to record their blood sugar and their blood pressure at home. So what we do is we use the patient waiting time, the patient waiting area as actually a patient education area. In fact, our receptionist goes into the patient waiting area and they take the blood pressure is actually taken in front of others also, because they also come to know of it and make sure that they know to record these things properly and correctly.
So
that education.
So in your case, the devices belong to patient.
No. Device belong to us only. It happens in
But
my
it's done
clinic,
there. Okay.
and it is shown to them, and they will buy the device and then they use it. But they are taught how to use it.
Okay, fine. Thank you. Arun, your stethoscope, your weighing
Yeah.
machine.
So I think health technology assessment in India is still a space which is lacking a lot. There is a health technology assessment in India secretariat under the Department of Health Research. But I think there are very few devices and the recommendations go directly from the government. So we, CHFI, as well as the Indian Institutes of Public Health, are part of this health technology assessment in India forum. We are a technical hub, and the Indian Institutes of Public Health are resource hubs for the health technology assessment in India initiative. But however, I think these are mostly for the devices that are made in India. And as Dr. Dilip said, the stethoscope that we're using, the cardioscreen, they have undergone assessments by other bodies like the FDA and the CE certification. And we've been using those. We have been looking at validation data that they provide from their various publications. If they have peer-reviewed validation studies that have been conducted, post-market research that has been done by these companies, we look into that data also. And we ensure that there is a high level of sensitivity or specificity when it comes to diagnostic tests, and also for the screening tools. We try to see whether the FDA and CE certification is there or if they have been approved by Indian authorities as well.
Thank you, Arun. Thank you very much. Ashwini, your blood testing machine,
So firstly, I would like to say, yes, we are also compliant with the FDA, ISO and all, but being said that, this is a screening device. I mean, this is not for a confirmatory test, and we are not trying to replace the regular blood test and everything, which is quite essential. But yes, this is used for the screening and for a provisional diagnosis, so the doctor can start an early treatment, and once the confirmatory tests are received, they can give a proper treatment. So this is more of a screening device. This is not a confirmatory lab.
Got it. I think that is very intelligent answer. Thank you, Ashwini. I think, see, the purpose of asking this question was very simple, and it will come to any patient's mind, and at least it comes to my mind being in quality for last 20 years. in my opinion, what you guys said is, you said your device is compatible to what the specifications are for that. It may be FDA, CE marking, or whatever is applicable to those. But that is equally hold good for any device which are being used by hospital in person, right? But still, those devices required validation. And it's not just one manufacturer. That gives a license that yes, this medical device is for this purpose, you can use it. But over a period of time, whether it continues to working in the same manner, whether it's continue to giving the same results as they should be, you need to validate. And there are many validation methods, like stethoscope. You can compare with your stethoscope with a normal stethoscope. Blood test analyzer, you can compare with that results with your own lab test results. So there are ways of validating the results coming out of these various devices, and I think that would be a way ahead and a next step for any digital application which you are using. And actually, that's actually precisely is a question comes to many regulators when they start challenging any innovation, you know. No, in this hospital you go and everything is done, we know what's going on. In this you don't. So I think to respond to that very collectively and scientifically, the answer is that we follow the same rules and regulation as I am in a hospital, because device is a device for purpose. Okay, I take that what you say, Asbani, screening. Yes, that's fine, but screening also range, right? If I use a glucometer at home, I know the range says 60 to 120, so it's a huge range, and sometimes I can be declared as hypoglycemic or sometimes maybe hyperglycemic, right? So I think there is a challenge, and I think there is a solution which can come forward. You want to say something, Sajid?
Yes. Regarding the glucometer, see, many times over a period of time, the accuracy of the glucometer goes down. So we have given a standard instruction to all the patients. Whenever you go to the lab to take blood test, take the glucometer also. Check yourself, check the glucometer also along with it. In the same minute, they check it at home and then they go to the hospital lab and then take the blood. It can be different. So we ask them to do it in the same minute and take the glucometer to the lab.
Yes, I think that's, and I think it's a long discussion we can get into, which I don't want at the moment, because to be very honest, you have raised very good point, and I have seen a primary health center when there is a glucometer patient coming and the person was taking. And I look at it and I say, I can guarantee that this is not working correctly. Why? Because the battery is weak. You have not even checked what is the battery life and how it is working. So if your battery is weak, your cell is weak, it's not going to get you the results correctly. And you are missing so many patients, you know, in the line. So I think I would suggest that you use the same quality assurance procedures for your devices as you would do in a hospital. So that will make your system perfect and pakka. Now coming to the next thing, what Dilip you mentioned in your presentation is about empowering patients and empowering providers. That's very strong commitment, I would say, because we are moving toward trying to move towards empowering patient, you know. Till now, no, it's only the empowerment is with the doctor. He or she would say, and patient will follow with this. So how you think that in your case, when you say empowering patient and provider, how you really built this so that it really translates into empowering patients? I'm not sure about the provider, but patients.
Yeah. See, the fundamental step there to do is transparency. So without transparency, you are going to have challenges where patients will truly become empowered because they don't know what is going on. So if you talk to doctor colleagues and healthcare workers, everybody is going to say, if you tell patients everything, then what about us? Won't they find faults? Won't they find errors in the system, or they'll question us? Well, that's going to happen. And it is going to be a tug of, the pulls in the system that eventually move the needle towards a more accountable system. But true empowerment comes when you have knowledge of what is happening to you, why it is happening, and do you have the power to change the outcome or the process. These are the three steps. And this can only happen if they're on the same platform where the care is happening, which is why you need providers also to be on the same platform. And then they have the ability to either change that decision or support that decision. So I'll give an example. So one of the concerns is, if the patient reads my note, won't they feel that there are things that are scary or they don't want to happen? Well, that's where you have an empowered provider piece. You don't need to show everything. You can have something in the software that says, okay, these are the pieces I would like to share with the patient because they're specifically curated for the patient so that they can understand what is going on with them. We don't need to show everything else. Perhaps then that triggers the patient to ask a question, okay, if I do this lab and this is wrong, what happens next? And you need to have a system in place, because that's going to generate more queries. You cannot expect the doctor to deal with that. But you can have a system that actually makes the doctor's job a lot easier, where, like you shared in your clinic, 9 out of those 10 questions can be pre-answered before the patient comes to the office. So same thing happens in the ICU.
Empowering.
That is an example of empowerment.
Absolutely, absolutely. And I think I take another question which is common to all four of you, is about when you use different processes, use technology, use devices in your ecosystem for providing care to patient, there are good chances of errors happening. And I think, and Dr. Saji, you mentioned about some statistics as well. And as we go to a hospital, we say, okay, you are having this much of infection rate, you have medication errors, you have this, downtime, downfail, and so many things, errors are happening, which are well-known, evidence-based. What is your experience, four of you, in your space, in digital health space? How do you really monitor any error happening in your continuum of care, I would say? Any one of you can pick up this question.
So, I would like to take this, if it's okay with everyone. So, of course, there is a chance of error in each and every system that we do. But if we have a proper backup, or for example, like I said, a patient care counselor, or a system in place such as a customer care, someone to help with them out, even if there is an error. Because however big or the small the system is, there is a chances of error, and there is no anything that could be done that it will eliminate it 100%. Yes, but if it happens, if there is a system in place which could help it, reduce it, and provide the patient comfort, it would actually help them.
Great, thank you, Ashwini. Anyone of?
So
Yes.
I can, sorry, please go ahead. Please
Yes,
go ahead. I can.
yes, Arun, go ahead. Arun, go ahead.
So there are a few ways, at least in our system, how we've tried to reduce errors. One is, again, through supportive supervision. We've put in a quality assurance officer that looks after the work of the lab technician, the nurse, as well as the data that is entered. But I think there is a lot of scope for preventing errors when it is a digital platform. Firstly, what we've done is we've used a very symptom-based, template-based history-taking system, as well as a capture of vitals. So there are automatic checks within each field. For example, there are numeric checks. If it is above a certain range or below a certain range, it automatically alerts them saying that this could be an erroneous entry. The other thing that we've also done is we've tried to keep them as, like how our multiple choice questions are. So, you have fever, and then you have a bunch of drop downs that come, and they need to click. So most of the information is pre-entered, and this also prevents them from making a lot of data entry errors. So I think these methods can be used to prevent errors, and I think it's easier when it comes to digital systems than actual manual systems, because over there, there's higher chances of misinterpretation, and the doctors are known for their non-legible writing. But then, these are all things that can.
Thank you, Arun. Yes, Saji?
I'm a cardiologist, so when any patient comes for angiogram or angioplasty, we have designed a checklist system. So the checklist has to be filled from the ward itself. The ward nurse has to fill it and sign it, and the same patient, before entering the cath lab nurse has to check it again and sign it, and then only the patient enters the cath lab. And the patient, if the checklist is not complete, the patient will not enter the cath lab unless it's an emergency, or only with the consent of the doctor. We've been practicing it for more than 10, 12 years, and because initially we missed, one patient is SBSAG positive, we missed that. One patient's creatinine is not available, or the patient had a creatinine was very high and we missed it. And this happened initially. So we finally, after implementing the check system, this error is not there.
Fantastic. Thank you so much. See, the purpose of this question asking was very clear to me, that people have this fear in mind, to be very honest. I am telling the experience from the users as well as from government regulators, which think, no, this may not. So I think this is nothing to be afraid of. This is what you guys have explained is another system, as we already have in a physical boundary, like a hospital, right? Only make sure is that you follow certain rules, which gives you a lot of confidence as well as your users. Like We are talking about AI, ML, technology, next level, and you take AI, right? At the next level of artificial human intelligence, right? Something like that, AI, is make use of that, giving you alert. In case you already have captured some parameters from the patient, and you use this digital tool, and you are going to write something like, for example, prescription of medication. And when I am putting it, it says, oh, no, hold on, it's a drug-drug interaction. You already had, this person has interaction, so stop it, it give me an alert. Maybe you can use those technology. Second thing is what you make checklist, self-assessment, self-evaluation, audit. You do your own audit, right? Or you can get the external audit, what we call accreditation. But before that, you subject yourself your own check. You have your own checklist, okay, this. I think that will make your life easy, confident, and everything like that. Okay. So,
do we have
yes.
time?
Yes.
Excuse me. I just have one.
I have a question.
Yes, please. Very nice.
Please carry on.
I am Dr. Latif Sheikh
Someone in the
from Maharashtra,
Yes, Dr. Latif, please.
and I have a question for Arun. In fact, unfortunately, I'm sitting here in Faisal in Kochi itself. I cannot make a presence over there. I wanted to ask Dr. Arun to please understand my case and please elaborate on telemedicine. Ours is a homeopathic clinic, and we are providing support to chronic patients. And in the follow-up, we are sending their medicines through the courier. And we are facing a lot of problems in this case because we have to receive the reports in follow-up cases and talk to them, and then send the medicine, again explain them on the telephone, on mobile communication. So we are facing so many problems in receiving reports, sending feedback, sending medicine by courier. So is there any scope for our clinics who are sending medicines by courier to the patient in the follow-up cases only? Or in some of the cases, even the new patients who are unable to travel from a long distance, they also ask to give the reports and send the medicine by courier. So I wanted to throw light on this. Dr. Arun, please.
So thank you, Dr. Latif, for your question. So at least in our program, we've not really got into the medicine dispensing part of it. But there are examples of platforms that have paired their telemedicine services along with an e-pharmacy service. So medicine dispensing, its inventory and its shipment is a very complicated process. And what our stand was when we started the program is that we're going to leave that to the experts in e-pharmacy, because you just pair your platform or your initiative or your hospital with an e-pharmacy that already exists. They have the logistics that is required for this delivery, and it makes it more sustainable. Otherwise, it becomes a very resource-intensive and difficult to sustain program when you pair telemedicine with e-pharmacy. And some of the things that I've heard from other telemedicine platforms that have tried pairing with this whole medicine dispensing part of it is that very often you don't factor in last-minute complications. Because, for example, if there is a drug that's been dispensed and they send it back, so then you got to, because the address is not found, or the drug is not what exactly it's not the brand name that they wanted, or if if it's expired by the time it reaches the patient. So there are a lot of things that's a whole set of different problems that e-pharmacy providers face. And I think as healthcare providers, it's easier to focus on providing the healthcare and letting the pharmacy providers do that part of it.
Thank you, Arun. Thank you, Dr. Latif, for your question. And I'll just come to you. Yes, your question, please, sir.
Yeah, I'm Rakesh. General observation for everyone. I think all of you are doing great work, technology, digital, and yeah. If suppose I'm a business owner, or if I'm a owner of a hospital, and then I see all these presentations, and it's not a critique, it's just a point of view. I think there is a way of trying to do loop how some of these things from a business owner's point of view, who is putting in his money to buy into one of these technological intervention, why should he do that? And there has to be either some improvement in efficiencies or top line patient. I'm saying so. Maybe even in normal presentation, maybe some of these things, if they can come out, I think it gives a far more 360-degree perspective.
Thank you, Dr. Thank you, Mr. Singh, for wonderful question. And I think I'll come to you. And what I understand from these 4 presentation, basically they themselves are the business owners, right? And you use your technology for your own purpose, means providing the care. Unlike there are technology platforms available. I make technology, the telehealth platform, and any hospital can buy, use it, right? So I am a hospital, I am buying your technology, using for telehealth or telemedicine. But in your case, you are using your technology, providing the care to the patient or something like that. Am I understanding, or you just respond to that?
So it's a mixture of both. That's a very good point. Our customers are hospital owners, so I can absolutely relate to that. If you look at our deck, when we are talking to customers, that's the line we take, and that's the line we should take. So there are 2 things we need to look at. One is either we increase the revenue for the hospital or we reduce their cost. So that is exactly how we would pitch and position what we do, because so for example, if our customer is in, say, Muzaffarpur in Bihar, there to get an ICU specialist is going to cost them a lot more than what an ICU doctor's salary is in, say, Bangalore, because of your urban metro supply demand mismatch. What we tell them is, we know you have a supply shortage. This is what you'll have to pay for a traditional model. This is what you'll have to pay for our model if you want the same quality. Why do you want the same quality? Because you want to show this to your TPAs, you want a reduction in your time to discharge, that is your ROI. So this is how we actually talk to them. And the other angle in which we would talk to them is that you have an ICU that has a 30% occupancy right now. If you take this service, you are now going to be more equipped, augmented to take more patients that are critically ill that you could not before. So you have a revenue upside and you have a cost downside. That's
Fantastic.
how we pitch it.
I think that's.
I would actually like to answer this question
Yes,
as well.
Ashwini. Yeah.
So, I mean, we also have few hospitals, so we are operating the hospitals also. So, it's not just we are selling the technology. We also have an operate and manage model wherein we actually help the hospital. So that's why I focus that, our target is small sized and medium sized hospitals. So when we are doing an operate and manage model, we are not just implementing the smart infrastructure, along with it, the manpower, the resources. As I said, smart hospital is a combination of everything together. And when we are putting the manpower and resources, it is actually to benefit the hospital, not in the operational efficiency, but also in the increase in the revenue as well as the growth. So hence, there are many different models which we can plug and play according to the hospital needs and requirements. It's not necessary that you have to take in all the technology. You can pick and choose whatever is required for you.
So
Thank you.
would
go
you
ahead.
like to be our customer in the future? We can take that discussion later. Thanks.
Owner to owner, technology
right.
transfer, I think that makes sense. And I think the question was very relevant and answer was also appropriate, that either they will increase your revenue or decrease the cost. In any way, you are going to get more money, right?
So Dr. Rana, I would like to add something.
Yes, Arun, yes.
I think the points that were made were excellent, but I think over and above the revenue and decrease in the cost, technology plays a very vital role in improving quality of care. Right? And by improving quality of care, you're improving the health outcomes of your patients. And with that, the user satisfaction, your patient satisfaction, not just through the improved clinical outcomes, but also the improved satisfaction that they get from visiting your healthcare facility.
Yeah.
And as far as I know, all hospitals spend a lot of money on their marketing and, on community outreach. And so it's about using technology effectively to build that connect with your patients and also build that trust with your patients while improving their satisfaction and their clinical outcomes. I think quality of care is something that's very important that technology adds.
Yeah,
Thank you.
thanks, Dr. Arun. I actually was trying to distill this, should I use 3 or 2? And the reason why we dropped quality when we went core business. He made the point about business, which is why I dropped quality. It's not because quality is not important. It's because if you scale quality, you are going to have patients come more to the hospital and increase revenue. So that is the link that I draw between quality and revenue, and that's only in a business talk. So
Yeah,
Great
I
point.
think it's a very good connection. And the two points which I asked, that do you validate your devices? Do you check have checklists? Do you do audit? That's actually was indirectly pointing out towards quality, that you ensure that the quality of care is as appropriate as to be in a hospital setup. So I think it's going a very good discussion over it. And I had a couple of questions around. We have time as well. My question is again is about, and it's common, like what we are talking about is, I'm sorry, it's not to saying something negative or something. It's just to, as a mind of an auditor, I'm a foolish mind of auditor like me, pick points which are somewhere missing. So you say you have the checklist and you have pre-filled form, patient fill it, and they come prepared so that you save time, right? But what about some terminology you use in the checklist which will not be understood by the patient? So how you deal with that, like micro, albumin area? Like I'm struggling
Yes.
to find what does it mean.
Yes. Yeah, that is true. See, the type of patients which we see are slightly different from the type of patients that is being seen in rural, in other parts of the country. Number one. Number two, we have a translation system also. There's actually, they can choose the language. They can choose a regional language or any other language. That facility is already there. So that is also possible. If they don't understand this language, they can change to Malayalam and then a regional language they are comfortable with, and then they can answer this question. That's how it is. And they don't answer the questions which they don't know.
Fantastic.
Yeah, and that's how.
Then you can ask
and we
when
get
they are
a-
in person.
A rough idea about this guy, the
Good.
person.
No,
coming
it
in.
just was a filler to the questions. And
I'm
I have one question for Ashwini, and then I will ask one question for everyone. Ashwini, to you mentioned your whole chain, right? This, and then prescription is coming out. It goes to lab for tests, it goes to pharmacy for medication and all sort of things. My question is, I read somewhere in telehealth ecosystem, you need to take a consent of the patient if you are sending prescription to pharmacy or some other place. So do you have a consent?
No. I mean, I don't think there is any concern, because even if I'm good, and this is only for OPD patients, this is not for the IPD patient, because even if I write a prescription as a doctor, the patient anyway has to go to lab and pharmacy. He has to-
Absolutely. Ashwini, that's the whole point I have. And you said it right. I'm only concerned with the OPD patient, not the inpatient. In OPD, the thing is that if I'm a patient, come to the doctor and he
No,
prescribe
you have
me.
to go and show the prescription.
And so I'm as a patient can go to any pharmacy, take my medication, nobody can stop me. But
No. He has to. So we also
if
give a physical
my prescription is sent to his pharmacy, you need to ask me, can I send this prescription for this, and
It
then
will
you
be-
collect the medication. That's my
No, it will
understanding.
be-
Because
will be-
you are sharing
it-
prescription, which is an information confidential to the patient with somebody else. Yes, external.
No.
Whether
It is
within
the hospital system. I mean,
Can I ask a
in a
question?
hospital
Yes, yeah,
information management system,
Okay.
it will anyway go to the pharmacy and lab.
I
If
just
they
ask
don't-
is in case, just in case. I'm sure you must be following thing, but yes.
Yeah, see, the prescription, if the patient has got a medical app, if the system has to be well oiled and streamlined, the moment the prescription is typed, it has to go into the app of the patient, which is in the hands of the patient. So
Yes.
he can go,
That is
forward it
fine.
to anybody else.
If patient is doing it,
Yeah, exactly.
patient can do anything. Patient do tick, 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 tick. It's in, now he's consenting, he's doing himself. Now, we know in India we have National Digital Health Mission, now renamed as Ayushman Bharat Digital Mission. Now, they have a very ambitious project, and you have 30 million or something more patient registered, individual doctor, hospital registered, and a lot of things are being moved. So, all four of you, how you see yourself, your things, with to connect with this Ayushman Bharat Digital Mission? What's your progression in that way?
Ayushman Bharat is a very good health initiative by the government. Actually, that's actually being a role model in our front. So that is actually a general aspect. We are actually dealing with specific type of situations, person to person, one to one. Actually, our aim is to improve the doctor-patient interface. So that way, it is actually complementing us. Most of the patients become digitally tech savvy also, because that also helps us, in fact, There is no
That's why they are generating ABHA, Ayushman Bharat Health, specific number
Yes.
to individual, all citizens. So if that is given, the purpose is you carry this number anywhere digitally and you need not to have the paper copies of your prescription and test and they will feed it, everything will be up. So I think your apps can get integrated and over a period of time it makes life easy. So now, all four of the speakers, do you have any questions for each other or for any one of us? Very
Not
nice
as of
smile.
now.
Fantastic. Any one of you present here any question for these four experts? Fantastic. Fantastic. I must appreciate that all four of you have made a very nice presentation, very clear, crisp, built on what the earlier session, the first session has built on, starting from physical safety, safety, and then, where is my friend, has gone somewhere? Oh, he's sitting there. Build, and then he was the digital person in that session and built on that. And you guys have really make it rocket, it's flying like this. This was really very fascinating. And that's, I think, people should know all these things, what are the advantages and the questions being asked, answered here, how you make sure, and I'm sure a few suggestions which I have put from my side you would like to consider to make your system more robust, more acceptable, more credible, more challenging to defend any question which might come to you as we raise questions to hospitals. Yes, Doctor.
Make one comment.
Yes.
When we talk about digital divide, our focus goes into patients. Tech-savvy patients, not the patients. Actually, digital divide exists inside the organization itself. I still know doctors who still don't give prescriptions. They just still keep on writing prescriptions. So that needs somebody to do a training kind of thing and getting everybody on the same platform.
It's like it's a joke, but it's a real example. When we say in quality, please write in capital letters. The simple reason is that if you write in capital letters, at least pharmacist or somebody can read it what you are writing as a doctor. So if you write like, you don't know what you're writing. So one very advanced case, when you're using it digital, you're typing in computer, you need not to follow that because you're typing it. But I see one hospital doctor typing in capital letter. I said, oh no, this is written in the standards, so I'm typing. So you know how you have the process, what is the purpose, and how religiously you follow sometime, which may not be required to do it in a lighter vein. So yes, gentlemen.
Thank you, speakers, for the wonderful session. I have one question. So all four of you were talking about putting a solution in front of a doctor, right? And now when you connect with different care providers, like you will have a bigger group of patients. How do you ensure that care is being provided to everyone who is reaching out to you for help? Like
Accessibility, you're saying, what Arun was talking about?
No. I'll specifically talk in case of Dr. Dilip's solution. So you are providing a ICU solution, right? And you will be having a system in place where some set of doctors will be monitoring this ICU from a remote location. So how do you ensure that throughout the time period these patients are monitored? Like basically you have to staff a good amount of doctors for this. So is this cost effective? Like how do you ensure that this is for all of you actually, because you have pitched different solutions here. So I want to understand from the hospital point of view, and I want to understand from the B2C point of view, like how every single patient is.
Great.
Yeah, good.
It's a solid question. So I'll take about a couple of minutes here. See, let's give you the patient story first. Patient story is very straightforward. If a patient needs to get the same quality of care that they're going to get in Patna, the same example, if they have to get it from Muzaffarpur, the only way is they have to travel 2.5 hours. Arun made this point that there are hidden costs with travel and stay. So that's one thing. The second very, very clear thing is that the per bed charge of hospital in Gaya, Muzaffarpur, Motihari, Bhagalpur, Lakhisarai, you name it, is about 1/3 or 1/4 of what it is in Patna. Okay, we know these numbers. This is out there in the public domain. You can do market research. That's the difference. What the patient needs to understand is that if they have a pneumonia, and if their outcome with pneumonia is just as good as it is in Begusarai when you compare it to Patna, they should stay in Begusarai. The patient should be where their care is the best for them, right? So that is the patient win. If they understand that they'll be spending 65,000 rupees in a Patna ICU, they should just be where they are best cared for. So that's the patient win. For the doctor and the administration, the linked value add is as follows. in a routine day, an intensivist can see 8 to 12 patients. That's how much they can do rounds on. However, in their rounds, they would be spending about 70% of their time doing work as an ICU doctor that can be done by either a nurse or a process or a system or a checklist. I hate checklists, by the way, but we'll come to that. So if they follow this schema remotely, that time of the intensivist can be saved. So instead of them seeing 10 patients or 8 patients, when they're in a network system, they can see 40 to 60 patients. So the tech there is acting as a force multiplier. That cost benefit is transmitted to the hospital, which is our B2B customer. So we tell them, you don't need to put a fully trained intensivist for your patient profile, because we do that. We are the subject matter experts. We tell them this is the sort of patient that you need an ICU doctor at bedside. That's a different patient, but 80% of the time you don't need that. So we tell them this is the cost benefit, this is how you can ration it out, and because of our force multiplier system, we can give you an 8 out of 10 system at a fraction of the cost that you would otherwise get. Of course, if you're a transplant ICU, you need a 10 out of 10 system. That's a different framework. So we will have to navigate the three-way between the patient, what's good for the patient, what's good for the hospital, and what's good for the doctor and the nurse. And that is how this technology actually comes to be a value add.
So you ensure that the doctor availability is there for 24 hours?
Correct. Correct.
This is a this is an app-based system. So we actually deal in a different setup altogether. This is actually acute care. We deal in chronic care.
Exactly. So you have a defined time period for working, or you don't?
No, see, yeah, we have, actually what we do is, we ask our patients, I ask all my patients to send their reports early morning, because I start working at 5:30 in the morning. So I ask them to send their reports early in the morning, and I categorize patients. For example, I categorized diabetic patients into 3 categories. Category 1, well controlled. Their blood sugars are well controlled. I tell them, you report only after 2 months. Second category is fair control. Some of the values are in, some are out. Third category is poor control. Poor control patient, I ask them to send values every day. It's my duty to bring them into the well controlled group till they are, so I am after them. I ask them to send reports every day. I tell them, consider me as a class teacher, not as a doctor. So I'm giving you homework, you send me daily reports. If they don't send me, I just have to type it PC, that is poor control patients, I'll get all the list. Who all have not sent it, I can send them reports. They send in the morning. So when they send in the morning, I immediately open I got a laptop where the EMR is there, so that I can tally it with and find out what are the things to be done and what that fine tuning has to be done. It's not a full prescription to be given. Just adjust this insulin this way, that way, or whatever it is. That fine tuning information is given. Not only that, it's sent by a WhatsApp. We use WhatsApp. It is exported into the email, and from there it is downloaded into the EMR. And I got about 600 patients doing this.
See, I think sufficiency and availability of doctor depends on the nature of the service. What Dilip is saying is a critical care patient. Patient is in ICU in 10 hospitals at 10 different cities. In his room, there are 10 doctors or 5 doctors who are sufficient for those 10 patients sitting in my room and monitoring what's going on. In his case, it's an app-based system. In these 2 cases, also a system is not an emergency and critical care. They are providing services as a patient coming to them as a teleconsultation or telehealth provider. So it depends on the nature of service. They cannot afford that, okay, doctor is not available for 5 hours. No, because it has to be looked at or whatever. So sufficiency in terms of number and availability to depending on the service is ensured what these 4 people are talking about. Okay,
Thank
so you have any question? I think the last question, I guess.
We have done this acute care even in a more escalated situation.
Please hold it closer.
Yeah, we have served this acute care in a more escalated situation like strokes. What we have done is people with strokes, when they have come in the US environment, in a hospital, we have installed what is called a pan, tilt and zoom camera. This pan, tilt and zoom camera is kept in the hospital environment. Immediately a stroke patient is come, the MRI is ported to a remote radiologist. Through our PAC server, he sees the image through a DICOM viewer and annotates the lack of bleed, there's no bleed. So it's only a thromboembolic phenomenon. It's ported to the remote neurologist, and he evaluates the patient through the pan, tilt and zoom camera, and in real time, the score is over 22. They have a methodology in this. they initiate the stroke protocol. The stroke protocol is they push IV tenecteplase within a bolus of 5 minutes. So this is a remarkable drug, the next generation of alteplase, and the effect is so beautiful. The golden hour is literally shrunk from door to needle. It becomes immediate delivery, and this is validated in the US environment where the malpractice suits are so strong. We push the legacy equipment also. The ECGs and the blood sugars are ported immediately in real time. The doctors can see, and the whole effect is seen there. So this can be done with a doctor located anywhere in Timbuktu, or the radiologist
Yes.
could be in Mars, and it's all done in real time.
No, I think it's a very important point and very good information sharing. And I think this is the next level. This actually depends on the regulatory environment.
And I brought it down here to this hall also. You can see this panel zoom camera. You can connect with any of your doctors, and you can port your PAC server through our PAC server, your digital MRI anywhere, and you can read it and simultaneously implement the care. As he said, this is the only solution. That is why it's going to be anytime, anywhere, to anyone, with affordability and accountability.
Absolutely.
This is where digital escalation is going to solve the pollution cost for the 1.3 billion people, or probably the rest of the world, as he said. Outside North America, rest of the world. Yeah.
I think that's next level for us. And when the regulatory regime is, Rama, you have something? Because regulations are also playing role, what you can't. Yes, Rama.
Yeah, just quick question to Dr. Saji, and even Dr. Arun was mentioning about digital divide. Arun was mentioning about the subpar utilization even in urban scenarios because of the digital divide. And Dr. Saji was mentioning about it. Now you're also talking about an urban scenario. Quickly, I wanted to understand what is the percentage of digital divide? Maybe in your own institution, do you feel that it's 60%, 70%, 80%?
Initially I was thinking it is only with the patients, and then now we know that it is with the inside the organization very well. So I can give you a percentage, but for my patients to use this app, they only need information or knowledge to use WhatsApp. I know people who can survive without water for 2 days, but not without WhatsApp for 2 days. So that is there. The percentage is there. It varies from patient to patient. At least 40-50 percentage of patients are also having this problem is there. Yes. Okay. As you said.
From practitioners' perspective, the digital divide.
Practitioners also, it is very rampant because it varies, ranges from a lot. I would say that it is close to 50% or more than that.
Absolutely, because
Yes.
when we are talking about digital
I got a
health,
suggestion to make, like, we need something like a digital transformation expert in the hospital who is actually in the center and plays a role. Make sure that everybody understands everything. The digital divide can be converted into digital synchrony.
yes.
It has to be a digital harmony. Then only things works.
This is why. This is just to create those counseling cells or transformation cells. This
Yes.
is why I was asking, because
Yes.
unless we break that divide, the digital health initiative
Exactly,
will
yes.
not.
It has to become synchrony and harmony.
Thank you.
An expert has to be there just for this.
Yeah,
We have an expert for like insurance. We have
absolutely,
an expert for all this.
absolutely. I was coming
We
there
need-
only.
we need an
Yes.
expert for this in the
That's-
hospital.
See, that,
It's
that
a
will
missing link.
That,
It's a
that
missing
becomes makes many things happen seamlessly.
Yes.
You can even break those barriers within the organization, even at
Yes.
a provider's level, and even at your
Right now in many
end
organizations, there is no such person to break the barriers.
Yeah. Yes, I think that's
Thank you.
also becoming an advocate for something, advocacy for something using a digital thing.
basic counselors,
is-
basic
yeah,
counselors
then-
are required,
yes.
and
So,
education,
fantastic.
more and more patient
Amasa,
education.
I can just quickly add to this.
Yes,
Sorry.
Arun. Yes, go ahead.
So regarding the percentage, the digital divide, I think for the approximate digitally literate households in India is around 38 or 40%. 60% are digitally illiterate. There are some government schemes that have been focusing on improving digital literacy in India. But coming to the physician, I think it's not a very simple problem. I mean, we're oversimplifying it by saying that, by capacity building or by simply asking doctors to do it or training them to do it, it's going to happen. There are multiple issues. Firstly, doctors themselves are not comfortable with digital devices. That's one of the problems. Secondly, the time that is taken by them to enter these details on a digital platform. That's another problem. When you go to a physician And if the physician is looking into an app or a tablet or a laptop while talking to you, the patient feels, that they've not been paid attention to. And that affects the rapport between the doctor and the patient. So these are all issues that happen, and that's the reason why, the medical fraternity has been a little reluctant to shift completely into a digital mode. But there are solutions, and many hospitals are, using a lot of very different solutions to combat this. One is direct upload of whatever's written in, into the hard copy, and there are a lot of softwares available that can convert them. The other thing is physician coordinators or assistants have been utilized by multiple hospitals to enter this data while the doctor can continue speaking to the patient. So these are just my inputs.
Thank you, Arun. Thank you. I think wonderful session. I would like to thank all the speakers. Very good questions, gentlemen, at the moment. You can come forward. You can come here.
Any legal issues you have encountered during treating of these patients in the ICU? Because patient attenders, they are happy when the patient becomes okay, and when patient dies in the ICU, so they will come up that doctor was not physically present and he has been digitally treated. So any legal issues you have encountered?
Yeah, this is a common misconception in the remote ICU space. Tele-ICU concepts or smart ICUs do not replace bedside doctors. So the bedside doctor is always there. This is an augmentary tool to help the bedside team do better than what they are doing. So we've never had a legal issue because we are the doctor's team. We are treating the patient on behalf of the doctor as their extended team. So if anything, we have actually had it go the other way, where the quality of care is at such a level where they're like, I didn't even need to go to a metro city. I'm getting better care here. I'm getting better attention here. So it's a little bit on the other direction, and we have a layer of protection because all of this data is digitized, auditable in black and white. We have patients of these hospitals coming to their doctor and saying, can you give me a printout from that system that was taking care of me 1 year later? So what happens in that case is the hospital owner or the doctor, whoever the case may be, are protected because they have all the data in legible format, like you were saying, no, in capitals or whatever typeface you want, but it's very clear. That is the transparency that we are bringing to the table. So will a legal case happen? Yeah, of course it will happen. It's a matter of time, not if, right? That's how medicine works. But it's obviously not been the case for us because nobody, and especially we, replace people from the bedside. That's not the use case actually.
Can I ask you a question?
Yeah,
Do you do this tele-ambulance? Because when the patient is transported through the ambulance, again, the care is not as good as being in the ICU.
Correct.
You can also monitor them.
We have done that. We've not taken it live. We've done it in a pilot setting, but absolutely there's a case for that. The golden hour starts when the patient gets into the ambulance, pre-hospital.
Pre-hospital thrombolysis and all those things are there.
We've done thrombolysis, as the other gentleman was mentioning, Dr. Srinath was saying. So we've done stroke care through the ICU, obviously, and in the ED. So we are functional both in the emergency department and the ICU. So ambulance is the natural extension.
Very good. I think this is what the advancement would come through. Now, when you are asking questions, and then people, oh, this was missing, now let me bring it into my system. Let me extend my service to this. And I think that's what the innovation will take the next level of healthcare to our country. So ladies and gentlemen, thank you very much. And I would now request all my presenter here and clap for themselves. And all of you, please clap for them. Thank you very much for Vandal. And I think we have some token of appreciation for them.